Well, thank you very much, Randy. It's a real honor to be able to spend time with you tonight. I think that it has been a remarkable evolution. Randy has not, Dr. Wyckoff has not spoken to his contribution to this effort. In the 90s, we really were looking at the development of a lot of antiretroviral drugs that started out as monotherapy with AZT and D4T, DDI, DDC. Some of these drugs have continued, others have dropped off because of side effect profiles. But it wasn't until the FDA, under Dr. Wyckoff's leadership, that we decided that these drugs needed to have a more rapid approval than was traditional for a new drug investigation. And started that whole process at FDA, which we were talking earlier today, has now resulted in 28 different antiretrovirals that have been approved, and takes on new generic formulations that are made largely in India to get these drugs made available to individuals at a fraction of the cost from the brand formulations, which translates into 3 to 4 times the number of people that you can put on antiretroviral drugs. So he was truly pioneered the role that the FDA has continued to play and now applies to cancer drugs and coronary artery disease drugs, anti-lipid drugs, etc. So really did have a sea change that has continued to reverberate. I'm going to go over a little bit of the epidemic from an epi point of view, and then talk specifically about the role that the President's Emergency Plan for AIDS Relief, PEPFAR, has played in mounting and sustaining a global response. As you can see, we have about 33 million people on the planet with HIV/AIDS. Of that, the vast majority, 22.5 million, are in sub-Saharan Africa, and then the rest are kind of peppered throughout the world. If you look at the United States, you've got the 1.5 in North America, about 800 to 1 million in the United States. We have about 56,000 new cases of HIV every year. It has moved into African American populations, Hispanic populations. 60% of the new seroconversions in the United States are women. They are women who do not perceive themselves as being at high risk because they're often monogamous, having one partner. But the scenario that we see is she falls in love, gets married, has a baby, and it's at the first prenatal visit that an HIV test is run and it's found that she's HIV positive. Go back to the husband and find that he's HIV positive and acquired his HIV remotely, 5, 10, 15 years ago, did not necessarily know that he was indeed HIV positive, either through having sex with men who have sex with men, or injection drug use, or in prison where men do have sexual contact but don't self-perceive or self-identify themselves as homosexual. Then get out of prison, get married, and that kind of scenario of the woman actually being exposed but not perceiving herself, again, is higher in African American and Hispanic communities. That 56,000 new infections every year in the United States has continued since 1994. So we continue to have about that many every year. And it's because it's in and amongst populations that are not well interfaced with the medical delivery system and stay outside of it unless they come in with later stage disease at the time at which you develop your opportunistic infections. Not much going on in Central South America. Europe having about as many as the United States had in Canada total. The biggest area of rapid growth in number of new seroconversions Sub-Saharan Africa remains number one, but the next big area for new seroconversions is in Eastern Europe. Eastern Europe has, in Romania, Bulgaria, Ukraine, Russia, are really epidemics that are largely unchecked. It's our biggest prevention opportunity now. It's centered in injection drug using populations and in sex workers. The problem is the governments in all of these countries have not acknowledged that indeed they do have a problem and have not mounted a prevention intervention strategy for injection drug using populations to try to minimize spread of both the hepatitis B and C, but also HIV through sharing of needles. One of the most effective strategies for containing the acquiring HIV in injection drug using communities is to have, in addition to drug treatment and medical care, psychiatric social services, to have a needle exchange capability. The natural history of addictive behavior for those who are using injection drugs is one of repeated recidivisms, and to not acknowledge that, people fall off of the wagon and go back into active drug use, and plan for it in your public health kind of safety net, misses the opportunity to prevent the spread of hepatitis and HIV in this community. And again, that becomes the conduit through which HIV enters the general population, the non-high-risk population, and is the main cause in the United States and Europe of vertical transmission or pediatric HIV. So Eastern Europe is the biggest place that is moving rapidly with new seroconversions. Eastern Asia, Southeast Asia has sex worker-driven epidemics and MSMs, or men who have sex with men, and continues to have some countries that have good responses, other countries that are just mounting a response, but the political will is pretty much there now. Southeast Asia, Australia. Australia was a men who have sex with men and an injection drug using epidemic. They're an example of a government who in the 90s responded maximally to their injection drug using epidemic and MSM epidemic and have contained it better than most other countries, really blunting the rapid ascent of new seroconversions in that country in the 90s. And it has not rekindled. So sub-Saharan Africa is where most of the burden of morbidity and mortality was from the beginning and continues to be now. So that is what PEPFAR, again, the President's Emergency Plan for AIDS, has attempted to focus on. President Bush started this program in 2003, made the argument that HIV was the main killer on the planet. It continues to be the main killer for women of childbearing age from 15 to 50. It is the main killer of women who are pregnant, which is globally still the case. But your ability to look at how HIV creates a death in a mother and a father, the millions of orphans that have been created by HIV in sub-Saharan Africa is stunning. And the instability that occurs in the family when the mother or the father die, the child is left alone, the stigma associated with HIV within the family and the community is high, and these children are often not embraced as other orphans would be, and are abandoned, become street children, become susceptible to survival sex. For the girls especially, and for the boys, they become subject to use in military engagements in sub-Saharan Africa. Sierra Leone, Cote d'Ivoire, Sudan are all examples of that. The northern part of Uganda, Democratic Republic of the Congo, we could go on and on. but a huge security risk. President Bush saw it as such, and as a result said that we need to stop this hemorrhaging, and proposed this emergency response that would deploy emergency strategies to put treatment capability in the countries that were most heavily impacted by HIV, and truly is an unprecedented response. PEPFAR is the largest program against a single disease that the planet has ever put together. It dwarfs the Marshall Plan for post-World War II Europe, and continues to be an extraordinary contribution of the American people, compassionate contribution to trying to diminish the morbidity, the death and dying issues that this disease continues to put forward. PEPFAR now has where we have tested now in this last year, 33 million people have been tested, 11 million people have received care. PEPFAR takes care of now 4.2 million children who've been orphaned, and that's from birth until they're 18 years old. It's food, housing, clothing, education, job training, social services, and follows them from 18 to in their mid-20s with a case management strategy that gives them resource to help keep them on track so they don't fall back into high-risk behavior. We have 434,000 children that we have prevented transmission vertically with PEPFAR since the beginning. Last year alone had 114,000 by the use of antiretrovirals during pregnancy and in the delivery stage and in the post-delivery stage. But we now are using 3 antiretrovirals on these women who are HIV positive and pregnant. It takes the risk of transmission from 27% with no antiretrovirals down to about 2% with 3 antiretrovirals, so a remarkable drop. We are about to launch a End Pediatric AIDS campaign that President Obama and Secretary Clinton are going to support. We are the main resource and program that will deliver it in partnership with the Global Fund for HIV, TB, and Malaria. Most of the contribution will, though, come from the American people, which I am finding with this budget climate. I'm trying to put that out in every venue I have. And then we have 3.5 million people who have received antiretroviral drugs from PEPFAR. That's about half of the people on the planet who have received these drugs. The total need of people who we know whose T cells are below 350 or 200 up until the new WHO change that occurred last year. 200 was the trigger for initiating antiretrovirals. Globally, it's 350. It's been changed to 350. It's about 13 million people who fall into the category of needing antiretroviral therapy with those criteria. We have about half of them now between Global Fund and PEPFAR have received the drugs and are continuing to do well. As you know, if you start these drugs and if you're in medical care with a knowledgeable provider, you probably should die from something else. They're that effective. We are also humbled by the degree to which your infectivity, as your viral load drops, so does your infectivity. Below 50,000, you drop precipitously. It's hard to transmit below 50,000. Below 1,200, it almost stops transmission. So from 1,200 a viral load to 50,000 seems to be the critical number. We now have a test-to-treat strategy that I'll be happy to talk to if people are interested in it, that is using treatment to saturate a population with HIV-positive individuals, placing them on antiretrovirals, getting their viral load down to undetectable, which stops transmission in that community. And we've been able to show this in Vancouver and San Francisco and in Thailand, and are now getting ready to take it to scale in South Africa, which is kind of the epicenter of the epidemic. PEPFAR is in 88 countries. The red shows the countries in which we have a large footprint. The blue are countries that are more technical assistance, where we train and work on implementation plans, but don't actually implement programs ourselves. In the red areas, we are anywhere from 40 to 90% of the response to HIV in these countries. So we are not playing a small role, we are playing a significant role, the significant role. Most of the countries in sub-Saharan Africa who are burdened with this disease do not have the resources and will not have the resources for many years to mount, to pay for the treatments. And our role and the role of others, and I'll talk to this a little later, through the Global Fund for HIV, TB, and malaria, we're able to get our European colleagues to contribute to this shared responsibility that we have globally to respond to this disease. And we hope that this economic decline will allow our European colleagues to continue to donate. So, the money for PEPFAR has gone up from $2.3 billion in 2003-04. We're now at about the 6.9 here in resources, $1 billion per year. So this is a very large program, and as I say, is in 88 different countries. The red bar shows our contribution to the Global Fund. The Global Fund puts out about $13 billion worth of program each year. We give about a third of that amount to the Global Fund. We are the largest contributor to the Global Fund as well, with the next country being the UK, who gives about a fifth of what we are able to give to it. The Global Fund, again, remains the platform through which countries that don't have a bilateral program, like PEPFAR, in countries, to still contribute to the treatment need, which is the more expensive component, or the prevention and care need in each of these countries. So it is a lot of activity. The fact of the matter is that most of the people on the planet who have HIV, in sub-Saharan Africa, 70% of them are co-infected with tuberculosis, HIV-positive people. In parts of Eastern Europe, the multi-drug resistant and extremely resistant tuberculosis is rising. In the Ukraine, for example, it's 13%. The point I'm making is that most of the people who are actively with HIV are often co-infected with TB. It's the reason that we've seen the spike in number of TB cases on the planet is because of the HIV. And we are able, with our USG programs, to put an increasing amount of money toward that. But again, all of the HIV-related resources also are treating patients with tuberculosis. So it's kind of one pot. Okay. The number of lives that we've been able to save flat out with just antiretroviral treatment, we're now at 3.5. We will continue to go up to the mid 4.5 million or so over the next 2 years. We're planned for that. We have budgeted for that. You can see that even with flattening of our funding line over the last 2 years with this economic decline, we have actually seen an acceleration from 1.7 million. So the first, since 04 to 08, we got up to the 1.7. And then because the medical delivery systems were in place, they were up and running, people had benefited from the antiretroviral therapy and brought in their family members and friends. So we've actually increased our rate of accrual in the last year and a half significantly, and that pattern will continue. This is Nguya, who's born in a maternity hospital in the DRC, the Democratic Republic of the Congo. She came in failing to thrive, had fallen off the developmental curve on every level. Her mother, pregnant with, this was her third child, had not had her HIV status checked during her prenatal visit, which she only had had one of, and never returned to the clinic to deliver the baby, and came in with the child after a year, and this is what the baby looked like, which is just very low, falling off of all the developmental curves that we would expect. With the initiation of antiretrovirals, and we have this in September now, from April to September, we have a baby that has fattened up, energy's gone up, cognition is approaching normal. The fact of the matter is that this program has saved lives, continues to save lives, and it's not subtle, it's dramatic. It returns the child to normal developmental landmarks. If we start antiretrovirals at birth, the baby has a normal developmental pattern for both brain and body, and it's something that I think the American people should take great pride in, because we're the only country that is doing this to the degree that the numbers that we're seeing turn around are really because of the support of the American people, and it's something that I am humbled by. PEPFAR has really tried to be a medical delivery system that is now up and running with doctors, nurses, healthcare workers, laboratories, pharmacies, procurement distribution systems, motor pools, etc. We have strengthened clinics and hospitals all over sub-Saharan Africa, Eastern Europe, Southeast Asia, that were not there before. They are there now. Our initial response was one of an emergency, where we were trying to just get a capability on the ground. We brought in experts who knew how to diagnose and treat the disease, and had them set up clinics and hospitals to respond to it using the medical infrastructure that was present, but oftentimes it was not available. You can't throw money at nothing. Something has to be there to receive it, to put a new capability in place. PEPFAR has been transformational in many of the communities in which we work, in all of the rural communities in which PEPFAR has put treatment capability. We have followed it up with prevention services that target high-risk populations, and attempt to identify those areas that are geographically kind of geomap where the new seroconversions are occurring in the country, and it is there that we put our highest and most concentrated prevention efforts. We have gotten very good at this, and we've gotten so good at it that we've been able to take our costs down from about $1,400 per patient on antiretrovirals down to about $187 per patient per year. It's a remarkable drop. It's been a combination of both medical delivery systems being up and running so we don't have to do that again, and benefiting from the infrastructure that's in place, but have also done it by moving from brand to generic, and we're now at about 98% generic in PEPFAR, and we've also done it by getting efficient with procurement distribution systems. Instead of having a separate procurement distribution system for every clinic and every hospital, setting up a new one, we pool the need, buy in mass, and are able to drop the unit cost, and also travel instead of by air, we travel by train, boat, or truck, and it has resulted in that $1,400 going to $187 per year number. We also have focused on gender. Women, 62% of the people with HIV in sub-Saharan Africa are women. It's about 52% in the United States. So that ratio remains constant in developed and in developing worlds. Women are very vulnerable on multiple levels in resource-poor settings. They are not equal in their ability to access education, to get jobs, and as a result become susceptible to individuals who will offer money to pay for food, pay for shelter for a sexual favor. This survival sex is a very common practice engaged in all over the world, Eastern Europe and in sub-Saharan Africa, and is something that PEPFAR has been able to put gender norm changing messages in workplaces for men and has had to scale. We've brought gender-based violence services to scale in Democratic Republic of the Congo, in Mozambique, in Tanzania, and in about half of South Africa. What that is post-exposure prophylaxis with antiretrovirals, pregnancy testing, treatment, diagnosis, and treatment of sexually transmitted diseases, emergency room capability that gives counseling, testing, and social services there on site. And I'm very gratified that we've been able to kind of piggyback this activity on much of the service in the service sites that we have for HIV. We are having combination prevention efforts, more than the 12 million new HIV infections. We have strengthening systems for care and support. Again, a target of 12 million. We're going to go up to 5 million for the orphans and vulnerable children. The burden there is about 15 million, so we're only a third of the way to addressing the need that we already know is out there. For the quality, more than 4 million people on treatment. We're at the 3.5 now. And the real effort that is new is trying to move our strategy, instead of an emergency response, to shift it to really expanding the capacity of these countries so these services are there for the duration, for 30 plus years, that they are sustained and part of the medical infrastructure of the countries in which we work. This has been a huge effort to change the agencies in the United States government through which we implement this program. USAID and the Center for Disease Control, HRSA, are the main ones that do it. The Peace Corps we use as well to get out into the rural areas have been dramatic in allowing us to now transfer these capabilities to local service sites, local community-based organizations, and medical schools and medical institutions in the country. This transfer of care and responsibility to manage and oversee these programs has required that we address the management deficit in these countries. The mid-level manager, the senior manager in clinics and in hospitals are not present in many of the sub-Saharan African settings we're in. And we're finding at this stage in PEPFAR's evolution that managers are the missing ingredient to sustainability. We can train the doctors and nurses how to use the drugs, how to use laboratory monitoring labs, etc., how to diagnose and treat opportunistic infections. The presence of antiretrovirals has dropped the number of opportunistic infections that were dominating in Africa down to very low levels now. And it really now becomes what was an inpatient disease has shifted in every country we're in to an outpatient disease. And it's quite dramatic. For those of you who were in sub-Saharan Africa in the 90s and the 2000s, in 2003, the entire continent of Africa, the 23 million people who were HIV positive on that continent, there were only 50,000 who were on antiretrovirals. Because of PEPFAR and because of the Global Fund, there are now about 6 million people on antiretrovirals. That number shifted an inpatient response that was inundated with patients with opportunistic infections to an outpatient one. The beds that you would see up until 2005, 2006, you'd go into any country heavily burdened in sub-Saharan Africa with disease. So South Africa, Namibia, Zambia, Zimbabwe, Mozambique, all those in the southern part of the continent had rates from 6% of the population infected up to 36% in Botswana. That's a staggering number, but what it looked like when you walked into any hospital in those countries are 4 people in the bed. You'd have 2 people underneath the bed, you'd have people in the hallway, in the waiting rooms, everywhere. It's hard to imagine what that looks like, but also put on top of that high rates of TB and cryptococcal meningitis. I can remember going into Zambia in 2000, maybe this was 2003, 2002, and these are open wards. These are old buildings and hospitals that have open wards, which are great for doctors and nurses, but patients hate it. But you could stand in the room such as this and see everybody on the ward just by being in the room. And to have 7 or 8 people with grand mal seizures going on at the same time, having 4 people in the bed, having the people underneath the bed, it is quite a shocking visual picture. But to see that degree of morbidity and mortality going on unchecked year after year after year, people waiting 6 weeks to 2 months to be buried because it's congested and full, running out of wood to make coffins, having graveyards bury people on top of each other because they don't have the access to land to bury people in their own graves, was the norm. And I just wanted to kind of remind you of that's where we were. And our ability now to move forward is predicated on our ability to continue these services. So, prevention. Prevention's the kind of what we all hope we can now turn to and effectively put in place. Prevention has been this elusive elf out there. We have looked at prevention since the early 80s in attempting to find that combination of interventions that changes behavior and keeps the behavior from high risk to low risk, sustains it. People can change for a while, but frequently fall back into high risk behavior, and it really has eluded us to find interventions that hold the line. Biomedical interventions are really more effective. I alluded to the test to treat idea, putting everybody who's HIV positive on antiretrovirals, dropping that individual's viral load, the amount of virus in their blood, but having what is now viewed as a community viral load that we look at, which drops infectivity and the risks of transmitting go down to 0. The biomedical interventions, other than the antiretrovirals that are highly impactful, are male circumcision. Male circumcision was something that was a surprise to all of us. None of us really thought this was going to be productive, but what happened is that we noticed that populations that had high rates of circumcision had lower rates of transmission in spite of being in high prevalence areas. So places that culturally circumcised males at birth had lower rates of seroprevalence. when you did large population studies. They took that further and tried to decide what it was about a circumcised penis that prevents transmission, and what it is around the head of the penis at the glands, there are a layer of cells in an uncircumcised penis that have high counts, high numbers of CD4 receptor sites on them, which is the landing site for the HIV virus. So a circumcised penis, from clothing, you rub that layer of cells off. So the chances of getting infected with any given exposure drops precipitously. In a circumcised penis, you take that individual's chance of getting HIV from the exposure down 63%. Now that's at a level of a vaccine, okay? It's a huge drop in the chance of that man acquiring HIV from an infected encounter. It does not protect the woman he has sex with, except in that the likelihood that he's HIV positive is diminished. So on a herd immunity level, we actually see significant drops in infectivity in populations that are circumcised. So it has become a central strategy to every prevention effort to put male circumcision in countries that have high prevalence and low rates of circumcision. We have latched on to this idea and this intervention and are doing studies in KwaZulu-Natal in South Africa where we're trying on a wedge design methodology to roll it out, implement our prevention efforts, but we're doing different combinations of prevention interventions, counseling and testing, condom distribution, safe sexual practices, matched with antiretroviral therapy and male circumcision for those populations that would benefit from it. And we're trying, as we implement it, to compare different combinations that we pile up and target a community where we do multiple prevention interventions compared to an area where we just put everybody on antiretrovirals. So we are going to be able to find out what combination of prevention interventions works best with which population. And we're very optimistic that this study will actually enable us to say something very, I think, dramatic. Our prevention efforts are about a quarter of our resources go to this. About 14% go to buying antiretrovirals, just to kind of give you a feel for it. So our prevention efforts really are central and becoming more and more of the main expenditure that PEPFAR is putting forward. The male circumcision, I just have this up here to remind me to tell you what I just told you. In countries that have high prevalence rates of HIV, low rates of male circumcision, we are targeting those. We are now going to Swaziland and have convinced the king, and we started this at the end of the summer, last summer, to get circumcised himself. And his doing that and blessing it has resulted in us moving to what will be about 64,000 circumcisions that we'll have completed by the end of this month, February, in Swaziland, which is a tiny country in South Africa, and we have found that if we truncate the time in which we make male circumcision available, do it in 3 months instead of 2 years, that we potentiate the protective aspects of in the larger community. So rates of new seroconversions drop more precipitously if we rapidly implement a male circumcision strategy. We've also found that that if you do this quickly, you will prevent all of those individuals from going into your medical delivery system as HIV positive, and you'll accrue over a 15, 16-year period up to the 2025 period from '09 to 2025. Our modeling shows that we will save that amount of money from people that do not go on to seroconvert and don't indeed congest the delivery system. The care and support services have dropped way off as we have put more people on antiretrovirals. Hospice care, home care is almost a fraction of what it was in 2004. This has been remarkable. So we have moved these resources that were there for hospice care, home care. We have moved them into really looking at strengthening our TB response in the community and doing gender-based violence activity for women and girls. It's been very gratifying to be able to use the HIV/AIDS platform to now open up to a broader portfolio of services. So, expanding treatment and ensuring quality. We have spent the last year and a half with the Obama administration taking the PEPFAR wins and gains and trying to ratchet down with savings. We've done that with pharmaceuticals by taking the drugs to generic. As I said, we have 88% in 9, but we're actually now up to 98% generic. And this, again, has allowed us to move those resources back into other prevention efforts, mostly, and have also been able to take a look at second-line therapy. We have about 3% of the people on first line go to second line. For those of you who are familiar with the United States statistics, it was more like 20 to 30% at Hopkins, at UC San Francisco, two of the first AIDS clinics in our country. Those rates are still in that range. Sub-Saharan Africa has the benefit from having not gone through monotherapy to dual therapy to triple therapy over we started with AZT in 1988, 1987. AZT was available, dual therapy around 89 to 92. In 93, 94, the protease inhibitors were discovered. In 95, 96, they became available widely. Those combinations of nucleosides with non-nucleoside reverse transcriptase inhibitors, with or without two nucleosides with an NRTI as the first line, and then second line adding a protease inhibitor to two new nucleosides with a protease inhibitor. Sub-Saharan Africa benefited from all the stuff we figured out here on day one. So the rates of developing resistance are very low. They're 3% on the whole continent of Africa. Our adherence rates with the patient populations in every country we're in are up around 92, 93%. For those of you who carry a cohort of AIDS patients in the United States, that's unheard of. We think it's because the drug combinations we didn't use D4T, we used AZT3TC and now tenofovir with FTC in combination with nevirapine or efavirenz are so low in their side effect profile that the adherence rates are very high. Sub-Saharan Africa has benefited from that. We are not going to be chasing a large wave of second-line need or third-line need. I ran a clinic at UC San Francisco where it was a resistance clinic, and we'd have people on 7 or 8 drugs. We could still get them undetectable, but they required 7 drugs to do that. Africa will not go that way because of the combination therapy on day one. We didn't have a population out there who had monotherapy and dual therapy and had high rates of resistant organism that they were carrying. So the wild-type virus in Africa is sensitive to everything still. We're doing surveillance of the virus in sub-Saharan Africa to see and document the emergence of resistance, but we're seeing, as I say, very low rates of it. The other activities that we're charged to do by the legislation is to train healthcare workers. We have started a program that has identified 20 medical schools in sub-Saharan Africa as the principal investigator to revamp their curriculum, make it more problem-oriented, put a residency for pediatrics, internal medicine, OBGYN, and general surgery at the end of their medical school training. Most sub-Saharan African medical schools pop the medical student out and put them in a 600 or 700 bed hospital where they're the doctor that covers all the wards, including the emergency room, do all the emergency surgery, do all the emergency obstetrical work that comes in, and burn out regularly and leave the profession and go into doing something else. That scenario has made a huge deficit in doctors and nurses. We have been charged in the legislation to try to train 140,000 healthcare workers. That would include doctors, nurses, and healthcare workers. We are having trouble meeting that. The brain drain in sub-Saharan Africa is significant. Much of the NGO, non-governmental organizations that come into the region swoop in to a city and hire up a lot of your talent and pull them out of the public sector. So we've kind of shot ourselves in our own foot. We've corrected a lot of these gradients to move back toward keeping people in the public sector, keeping them in the workplace where they are, and supporting them in that setting. We're getting better at it, but it's still a big problem. So we have really come up with this theme of country ownership. By that we mean these countries not having Harvard or Columbia coming in and setting up 30 clinics and 2 hospitals in a capital city in sub-Saharan Africa, running them with people, expatriates who are from New York or Cambridge, but people who are there are in and of the country is what the new PEPFAR is focusing on. We are identifying physicians and nurses, expanding their personal portfolio capability by training them, but then we are reinforcing, giving them a living wage so they don't have a low threshold to leave and go work for a non-governmental organization or the UN or WHO. That ownership will include eventually resources from the country, but what we've created is a mechanism called a partnership framework where the United States government signs an agreement with the president of the country or with the Minister of Health or Minister of Finance or the Prime Minister to you do this and we do this over the next 5 years, and map out a glide path that moves the management, the definition of unmet need, the prioritization of that unmet need to the country leadership, where we in Washington or in Geneva are not making decisions for what's going on in Kampala, which is what the traditional development strategy and does. Those decisions are taken out of country. The accountability is taken out of country. Patients who use these services to complain about a service being effective or not effective have to talk to us in Washington or talk to us in Geneva. And that has created a real schism. I didn't realize it was so late. I'm sorry. Let me move a little faster here. So in order to take advantage of these platforms that we've created, the Global Health Initiative is a phrase that President Obama has come up with that basically is taking vertical programs that the U.S. government has up and running, such as PEPFAR, and now putting other services available at that one site. So that clinic now will not just treat HIV and AIDS, but will also have maternal and child health, family planning programs, or we'll have immunizations and clean water programs. So that's how that has worked. We also give about a third of the money to the Global Fund. We gave a large amount of money in October to them because it is our best partner in this work on the planet. And it is, as I said, the conduit through which other countries, mostly European countries, can still contribute, but who are not willing or able to have a bilateral program of their own. So it becomes a way to share the responsibility and burden of this disease. So going from an emergency response, we're now building sustainability, and we're well into this now and moving rapidly with our partnership framework strategies. But the self-sustaining response is really predicated on civil society, getting the people who use these services and those in and of the community to hold the government accountable for continuing those services or for improving them. And we have developed some strategies as occurred in the developed world, in the United States, in Canada, and in Europe. The AIDS advocacy phenomena that we saw occurring has not occurred in any of the countries we're working in to any degree. The stigma, you are HIV positive in many of these settings and you are ostracized by your family. Homosexuality, you are stoned by your own family and friends to death in many of these countries. For injection drug use, the same. So people don't reveal themselves, and as a result, the ability to hold the government accountable for putting that service in place is diminished. So we're trying to support that civil society voice and have a number of things, and I'd be happy to go into that with you. I'm ending here. The United States puts about 60%. We're actually up to about 68% in 2010. Because of the economic decline, we didn't diminish our contribution. The next closest country is UK at about 10%, but you can see all these other European countries are 1 or 2% of the global response to HIV, TB, and malaria. So the American people should be proud of what they do. And as Randy was alluding to, we have started something that I know we won't finish. Our generation has been there and responded as best we can, but it is your generation that's going to get it across the finish line. We could not have a more exciting topography to work in. You will not have an opportunity to alleviate as much suffering, to stop as much death as working in global health. The gratitude and the richness of the contribution you make is extraordinary, and I would challenge all of you to keep that in your sights as you move through your training and get your career to the point where you make a decision as to where you want the bulk of your contribution to be. For those of you who are going to stay domestic, there is always a role and component of support that you can align with in a global effort on multiple levels. The school here has many opportunities for you to not just work and learn in these resource-poor settings, but to contribute. And it's that contribution that this program has started, but again, it's the contribution that I hope you will all finish. So I'll stop there and open it up to questions.
Good evening, Dr. Goosby. I'm Michael Harney. I'm a worker at the Western North Carolina AIDS Project in Asheville, about an hour east of here, and I operate a needle exchange program too, which is still illegal in North Carolina. Just wondering if you might address the criminalization a little bit more of HIV. You addressed it a little bit. Wondering if PEPFAR is still restricted from funding needle exchanges around the world. Public sex workers, a major component of transmission, but are you restricted from funding interactions with public sex workers? And wondering how we might be able to get the ADAP crisis in this country, the AIDS Drug Assistance Program crisis, reduced, and maybe bring the $187 a year per person for antiretrovirals. Is there any way we could do that around this country?
Well, those are all great questions. PEPFAR did have language in its reauthorization in 2008, which reauthorized PEPFAR to 2013, that restricted the use of resources. Well, let me back up. Family planning services, the United States government has a law, and has had it for many years, that U.S. dollars are not used for abortions. That law applies to PEPFAR. But family planning services are needed desperately, and they're needed often in settings where sex workers are working. And the legislation contained a prostitution clause that focused on not giving any U.S. dollar to an organization that promoted the women going into prostitution. That's almost a quote. It was a very strange clause. It was an attempt to restrict U.S. dollars that could possibly be involved in legalizing prostitution, was really the intent. The Obama administration has not required that clause anymore, and we have never in PEPFAR been restricted from supporting needle exchange programs. The Bush administration, though, had decided to have no PEPFAR dollars go to needle exchange. Since I've been in this position, we have moved to supporting needle exchange programs for all the reasons that we alluded to, and are just revving up with that in Eastern Europe, in Tanzania, in Kenya, and in South Africa, where injection drug using epidemics are known and active. We have been ignoring those individuals and allowing them to get infected with hepatitis and HIV for the first phase of PEPFAR. That's changed, and we're trying to catch up, and we will catch up. In terms of the drug costs for ADAP, that's something that we're really not connected. Our buying that goes on in sub-Saharan Africa, for example, is not really available to the United States. The move to generic was more aggressive in the PEPFAR procurement systems than they are in the United States, but that has changed also, and I think over the next few years the cost will drop precipitously. But we're an unusual country with a large, 85% private funded insurance. And then with healthcare reform, we've brought another 30 million people into care. So out of the 15% that weren't covered, we've brought in a good chunk of them. But it's still all insurance company driven buying that's going on. So the U.S. government's ability to influence that outside of the VA system, which we do influence directly, is limited. So I'd have to think with you about how we could take advantage of it. It's a good thought, though.
I was wondering if you could address any kind of work opportunities or volunteer opportunities that students could have with PEPFAR.
Sure. We are going to have more and more. We haven't had many. Senator Frist has been all over us to figure this out because he's got this really a wonderful idea of an exchange capability that he I know has done things with Randy already but he wants to bring it to a large scale with PEPFAR. To open up PEPFAR's programs would create thousands of sites that are well-staffed with faculty that can give the support to a student to really have them be on a steep learning curve. We are looking at doing that. There are also opportunities through the Peace Corps, coming in through the Peace Corps with a health degree. It's not just for kids in college, but people with nursing degrees, medical degrees, dental degrees can now pretty much call their country where they, if they're willing to commit to a year, 6 months at minimum, but more commonly a year of work, they won't have the 2-year requirement that the typical Peace Corps volunteer has. It's volunteer. We're trying to put a paid capability in place with Senator Frist's activity. And we will probably be successful with that over the next year or so. So I'd be happy, through Dr. Wyckoff, you could access me to help you think through it when you're getting ready to try to find something, because I'm aware of a lot of NGO opportunities that would probably be available immediately.
First off, I'd like to thank you for coming. It's been a great experience.
My pleasure.
Referring to male circumcision, the last I heard, the CDC still did not have any proven support for male circumcision, and I was wondering if that's changed with the statistical information you had in regards to developing countries and how that has influenced HIV rates, and if that change would be coming, or if I am misinformed and a little late in my information.
So your question is, does our Center for Disease Control endorse male circumcision?
Currently, yes.
Yeah, they do. Yeah, the data now is not disputed. It's real clear. That 63% drop has been repeated in 2 other studies. The Swaziland experience, we're doing it in Swaziland and Zimbabwe and Zambia. In all 3 of the countries, word has gotten out that by the partner that women are insisting that their men get circumcised, and they're saying that they'll have more sex if they do, because it's cleaner and all of that. And we have been blown away at the lines that have come into male circumcision. We kind of set up a MASH unit, and like in the parking lot, and set up, we have surgeons and nurse practitioners, PAs, all of whom have been trained in how to do it. We could teach you how to do it in a day. And we have waiting lines that are virtually in all 3 countries. People will wait all day and come back the next day. So word has gotten out, and it's cool to get circumcised now. So we actually thought it was going to be kind of a non-starter, but it's been just the opposite.
I would like to know if the PEPFAR and the Global Fund, if they have an oversight agency, because I am a Nigerian, and I know that sometimes I've heard stories when I was in the country where monies donated by international agencies are often embezzled by an individual. So who provides oversight for the monies that are donated to these health systems?
Well, for PEPFAR, we do not give money directly to governments. We give money to a non-governmental organization that then will work in the Ministry of Health, but the money for that employee goes through a NGO. We've also set up parastatal organizations, entities, that just receive the money and play a fiduciary role with the money to dole it out in payroll or in procurement, distribution, whatever costs that they give it to, that the government controls and makes the decision, but it is transacted by another entity that is transparent and auditable. We can follow every dollar in PEPFAR. In Global Fund, it is less clear. it is not that clean. They give money to government that goes into one pot, and the best intended government, not corrupt or stealing any of it, can lose track of how $100 million moves through their system in something that is quickly moving through those resources, unless they are sophisticated in their ability to track the money. Most of the problems that you read about in the Global Fund over the last 3 weeks were minor transgressions, trainings where people were given daily vouchers for food and for housing, and they didn't collect receipts as a result. That's what the transgressions were and what hit the API news media and created all the uproar for Global Fund. Nigeria is very good at it. The president in Nigeria, Jonathan Goodluck, is a biologist by training. When he was governor, he had a very progressive, during the 90s, resource kind of payments that would go to HIV-infected people in his province. He has embraced the PEPFAR model, and we are going in Nigeria from about 5% of the AIDS response in Nigeria paid by the Nigerian government. Now, over the next 5 years, they're going to go up to 33%. That's a huge change, and it's because of his leadership and because of the oil that they're able to do that. So I think it's something that you hear a lot more about than is really a problem, but it's something we need to keep that transparency and accountability in place and hold people accountable.
Well, Eric, thank you.
Sure.
Before you go, and I'll ask for a round of applause in a moment, we do have some parting gifts for you.
Oh.
Yeah, it's a tradition. We're sociable here.
That's great.
Yeah. First of all, we're very honored and pleased to have you here.
Oh, that's neat.
And in
Thanks.
return, we'd like to offer you the title of Honorary Professor in the College of Public Health.
Oh, that's great. That's really cool. Thank you.
And
thank you so much, Randy. It's very sweet. Thank you.
And then, so that you don't forget your visit with us, a few memorabilias and the Encyclopedia of Appalachia, which they need to read in Washington. It's slightly smaller than most legislation.
Yes, that's great. Thank you.
We'll mail this back for you.
Oh, that's great. Thanks.
But Eric, thank you. And I got to tell you, as you know, I used to work in this area a little bit.
know.
And I'm stunned by what you guys have accomplished. It really is
Yeah.
dramatic. So
Well,
thank
thanks,
you.
Randy. It's coming
Thanks
from
for
you.
being
That really means a lot to me.
here.